Hello, my name is Peter Higgins and I'm an IBD specialist at the University of Michigan. And welcome to the IBD School 200 series. In this video, IBD School 208, we will be talking about rescue therapies and exit strategies. Frequently, IBD patients will be stable for a long time and then have a flare of symptoms. The patient will go from no pain and normal bowel movements to having a lot of pain and cramping, bloody bowel movements, mucus, and having to rush to the toilet all the time. In these situations, we naturally want to help them quickly to rescue them from their flare as soon as is possible. Generally, at this point in time, our fastest medications are steroids. Typically, if a patient is moderately sick, we will give them prednisone tablets as an outpatient. However, if they are very sick, we will bring them into the hospital and give them steroids through an IV directly into the vein, thus improving the absorption and speed of action. Occasionally, for very sick patients with ulcerative colitis, we may bring them into the hospital and give them cyclosporin through an IV in hopes of avoiding surgery. In general, rescue medications work in just a few days. They do their job and rescue patients from their flares. Because they are being used for such short periods of time, we are willing to risk certain side effects. And steroids have a lot of side effects, including not being able to sleep, being really hungry, being irritable, and having labile changing emotions. Cyclosporin can even put you at risk for a seizure or kidney failure. Therefore, none of these rescue medications are something you would want to use long-term unless it was critical to your survival. These are what we call rescue therapies. When you need them, you really need them, and it's worth doing. But once you begin getting better, you do not want to stay on these medications long-term. For long-term treatment, you want to be taking what we call a maintenance medication. Once the emergency is mostly over and the patient is less sick, it is necessary to think about what will be a good long-term therapy option with fewer side effects for this patient, one that you can take for years to come. At this point, we are considering a whole different class of medications than what we used during the rescue. When you start a rescue therapy, you're basically putting out a fire. It's an emergency, so it's okay to use a fire extinguisher and make a big mess. But you wouldn't want to be doing that every day. If you owned a kitchen and you needed to use a fire extinguisher more than twice a week, you don't have a very good chef. So when you start a rescue therapy, you need to have a plan for getting off of it. You need what we call an exit strategy. What is the maintenance therapy that is going to keep you from needing the rescue therapy again anytime soon? When we start a patient on something like cyclosporin or steroids, we want to transition them onto a better maintenance therapy. Either their current maintenance therapy at a slightly higher dose, a different dosing regimen, or a better therapy that will keep them out of this situation in the future. Ideally, we won't need to use rescue therapy more than once every 3 to 5 years. If you find yourself getting rescue therapy more than once a year, you should ask your doctor why your maintenance therapy isn't working, and ask, what therapy could I use to avoid needing to be rescued so often? I'm Peter Higgins, and thank you for watching IBD School 208.